ultrasound of the gallbladder, and these are where I've got my images from, some of my images. So what will we discuss today? We will discuss normal gallbladder ultrasound, congenital abnormalities, gallbladder stones and sludge, acute cholecystitis and its complications, chronic cholecystitis, polyps and adenomyomatosis, gallbladder carcinoma, and miscellaneous conditions like volvulus and non-visualization of the gallbladder. Can you all hear me? Okay. Let's talk about normal gallbladder ultrasound. As we all know, the gallbladder is divided into a fundus, a body, and a distal portion that is called the neck. Just prior to the neck, there is a cystic dilatation of the gallbladder, and that is known as the Hartmann's pouch. This is a focal area of dilatation just proximal to the neck, and because of its pouch-like appearance, stones, calculi, sludge balls like to lodge in that region. Once they lodge in that region, it's hard for them to escape. Therefore, the Hartmann's pouch is an important area. As we see, this is a region of the neck, and then we have the cystic duct. The cystic duct sometimes has a spiral valve within it. It's called a spiral valve of Heister, and this can be seen on ultrasound. Occasionally you can see this as a S-shaped configuration of the proximal cystic duct, and that indeed is the spiral valve of Heister. We know that the cystic duct combines with the common hepatic duct and forms the common bile duct. The common bile duct empties into the duodenal papilla via the ampulla of Vater. Any questions on normal anatomy? Now, a normal ultrasound of the gallbladder. We request that all ultrasound examinations of the gallbladder be performed with 6 hours of fasting at a minimum. We do subcostal or intercostal scanning. We will do scanning in the supine, left lateral decubitus, prone and upright position. We can do that to see if there are some sludge balls adherent to the wall of the gallbladder, just to differentiate a polyp from a calculus, to differentiate tumor from a sludge ball. All these maneuvers may be helpful. Normally, the gallbladder wall thickness is less than 3 millimeters. And when we measure the gallbladder wall thickness, we are looking at the anterior wall of the gallbladder on a sagittal view. And we are measuring it perpendicular to the long axis of the gallbladder. Is that clear? We are not measuring gallbladder wall thickness on transverse view. Sagittal view, anterior wall. On the transverse diameter, if you were to measure, the transverse diameter of the gallbladder is usually less than 4 centimeters. That is, this width of the gallbladder is less than 4 centimeters. Here they're trying to show you the fundus, the body, and the neck of the gallbladder. This focal dilatation is the Hartmann's pouch. Gallbladder folds. When we do the longitudinal view of the gallbladder, many a time we can see that a gallbladder lumen is not constant. It is not of the same caliber from the fundus to the neck. It is invaginated by various folds, and those folds can easily be either removed from the image depending on what is our angle of incination. Here we are redemonstrating the Hartmann's pouch, which is just proximal to the gallbladder neck, and this is the region of the gallbladder fundus. When the gallbladder fundus folds itself upon the gallbladder body, that is called the Phrygian cap deformity. It can be a small Phrygian cap and can be a large Phrygian cap. Why do we need to know this? Because sometimes calculi can get lodged or sludge balls can get lodged in the Phrygian cap, which is difficult to escape. Now here we're just showing you various kinds of gallbladder folds. We see them very commonly. We can see a fold here between the neck and the body, a fold between the fundus and the body, which is a Phrygian cap, and here we can see multiple folds. We see them all the time. They're inconsequential. It's just that the technologist needs to tell us that is a fold, and we should not mistake it, you know, in this case for a polyp. All right. Part of a fold within the gallbladder may produce an acoustic shadow. When only part of this fold is visualized, it may mimic a polyp or a stone. Therefore, it is important for the technologist to tell us gallbladder indeed had folds, because sometimes we can falsely assign this as a gallbladder calculus. This ultrasound image is not uncommon. We see it all the time. Shadow near the neck of the gallbladder on longitudinal section, absence of visible stone at origin of the shadow, and scanning in different positions can help us alleviate what is known as the edge refraction shadow. So the edge refraction shadow happens at the posterior wall of the gallbladder. When you see dense shadowing occurring from the posterior wall of the gallbladder, note that this shadowing is not occurring from a content of the gallbladder lumen, but is just a function of the gallbladder wall. And this will disappear when you make the gallbladder when you view the gallbladder in transverse section, and also there will be no shadowing emanating from a echogenicity within the gallbladder lumen. Scanning in different positions, changing position of the patient can help alleviate the artifact. Excuse me. Now, this is a proximal cystic duct. As I told you, you can have an S-shaped configuration of the proximal cystic duct. This serrated appearance that you see, which is these folds, if I may say, in the S-shape, are the valves of Heister, and they can occasionally be identified in sonography. My technologists are here and they can tell you so. It's important not to mistake these valves of Heister, which are these tiny echogenic foci from calculi. These will be non-mobile and they will only be seen in certain projections. This is the longitudinal view of the gallbladder neck and proximal cystic duct, where we are seeing not only the spiral valve of Heister, but we are also seeing the proximal cystic duct, which has an S-shaped configuration. This is a normal cystic duct, which is a dilated cystic duct entering the CBD posteriorly. So we have the common hepatic duct, cystic duct, and the common bile duct. Let's start first with the congenital abnormalities. What are the congenital abnormalities that we know of? One is agenesis of the gallbladder. How do we determine agenesis of the gallbladder? So patient will present at birth and will have the stool color will be different than that of normal, will not contain the normal biliary pigments. That's number one, when the patients will, or the physician will start thinking of some abnormality with the biliary system. Anomalous gallbladder location, and we will discuss the abnormal locations. There could be duplication of the gallbladder, which may be suspended by 1 or 2 cystic ducts. There could be a septated gallbladder where it has a honeycombed appearance, and a gallbladder diverticulum, which can occur in any location. Let's talk about the few abnormalities. A duplicated gallbladder. In this patient, you have a common hepatic duct and a cystic duct. A single cystic duct suspends 2 gallbladders. This is a gallbladder diverticulum, which can occur anywhere. Here it's occurring in the region of the neck of the gallbladder. And this is a septated gallbladder. This is a cross section that shows you that there are multiple compartments of the gallbladder lumen. Agenesis of the gallbladder. It occurs in 1 in 6,000 live births, and fewer than 300 cases have been reported in history. It was first described in 1701, failure of the cystic bud to develop in the 4th week of life. That is the congenital anomaly. It is associated with a variety of chromosomal abnormalities, and the symptoms are attributable to biliary dyskinesia. Ultrasound diagnosis is non-visualization of the gallbladder. We call that absence of the gallbladder, and the HIDA scan will show you findings that are similar to acute cholecystitis. So what do we see in the HIDA scan in patients with acute cholecystitis? Everything fills up. The cystic duct fills up, the common bile duct fills up, but the gallbladder does not take up the contrast because of an inflammation. Similar findings are noted on the HIDA scan. However, the diagnosis can only be confirmed after surgical exploration. So let's look at the HIDA scan. So here you see on the 20-minute image there is uptake in the liver, and then there is excretion into the common bile duct and subsequently into the small bowel. There is no visualization of the gallbladder. There is no gallbladder seen on the HIDA scan. On the MRI and the MRCP, there is no visualization of a normal or an ectopic gallbladder. However, the biliary tree is normal. There is no evidence of Caroli's disease. There is no evidence of a choledococele. There is no intra or extrahepatic biliary ductal dilatation. The CBD appears pretty good, going all the way down to the ampulla. So that was number one, absence of the gallbladder. Coming second to the anomalous location of the gallbladder. It is very rare. It's only reported in a couple of isolated case reports. What are the most common locations? That's left-sided, posterior to the left hepatic lobe. Normally, you see the gallbladder location in segment 4B, adjacent to segment 4B, right? Here you are seeing the gallbladder location adjacent to segment 2 or segment 3. So it's more left. It's more left than more right. The intrahepatic gallbladder, that's what we see over here, that the gallbladder is seen surrounded by liver tissue on all sides. That's not normally true. A suprahepatic gallbladder, a gallbladder interposed between the right hemidiaphragm and the right hepatic lobe, and a retrohepatic gallbladder which is seen posterior to the right hepatic lobe. Here we were just seeing that there is an intrahepatic gallbladder. It's important to identify these anomalies because these may preclude laparoscopic removal of the gallbladder in future life. Duplication of the gallbladder. So 1 in 3,000 to 1 in 4,000 gallbladders may be duplicated. 2 gallbladders adjacent to each other, here we see, and we may have 2 separate cystic ducts, or they may be suspended by 1 cystic duct. After meals, both gallbladders will show normal emptying. If they're normal functioning gallbladder, they will contract normally. Why is this anomaly important? This anomaly is important at the time when the gallbladder is inflamed. It's important to remove both the gallbladders. Number two, this will also preclude laparoscopic removal of the gallbladder. A multiseptate gallbladder, it's a congenital variation. As you can see, you see a distended gallbladder with multiple folds that appear to be complete. They are complete folds, not incomplete fold, and they cause what is known as compartmentalization of the gallbladder. It may involve the entire gallbladder or part of the lumen of the gallbladder. The chambers communicate by orifices. They could be isolated or coexist with other anomalies, and symptoms of recurrent acute cholecystitis. Multiple linear fine echogenic septations oriented horizontally or vertically. That's what the finding is in patients with multiseptate gallbladder. Now coming to a true diverticulum of the gallbladder. It's extremely rare. It occurs anywhere in the gallbladder. It usually is single and it varies in size. Like here you have a gallbladder. This is the region of the fundus, and there is a small diverticulum arising in the posterior wall of the gallbladder fundus. All right, any questions so far? Okay, let's go ahead with gallbladder stones and sludge. Ultrasound of a gallbladder stone. So ultrasound is the gold standard modality for diagnosis of cholelithiasis. What are the three sonographic criteria for the diagnosis of gallbladder calculi? Number one, there has to be an echogenic focus. Number two, that echogenic focus should cast an acoustic shadow. And number three, that stone should seek gravitational dependence. If we are able to establish all these three criteria with confidence, we can say this is a stone. However, we should know, and our technologists know, that there could be different angles of insonation where you may be able to elicit a better posterior acoustic shadow than others, and you can have to change patient position, etc., to show us that this actually seeks gravitational dependence. Stones that are less than 2 to 3 millimeters may be difficult to visualize via ultrasound. Let's look at what are the three patterns of shadowing that are elicited by gallbladder calculi. Number one is a clean shadow. A clean shadow is there is a single stone and there is a shadow or a dark echogenicity posterior to the stone in line with that stone. What's confluent shadowing? Confluent shadowing is shadowing that occurs in a setting of multiple stones. And then we'll talk thirdly about the wall echo shadow complex, which is a gallbladder lumen that's packed with calculi. Also to know, soft pigment stones may not calcify. These are pigment stones patients usually who have some hemoglobinopathies or patients who have some vasculitides who may not show calcific stones. All right, so confluent shadowing. Confluent shadowing occurs when there are multiple small stones that gravel and abut each other, and we have a confluent shadowing that occurs posteriorly. That is for one reason. Because of the presence of tiny calculi, we never assume the posterior gallbladder wall as a wall that we should measure to identify gallbladder wall thickness. Invariably, the anterior wall is the one that should be measured, because posterior wall can be lined with tiny pigment stones that may not be shadowing, however, may increase the size of the gallbladder wall posteriorly. This is a confluent shadow. You see a bunch of echogenicities and you see shadowing posterior to that. This is acoustic shadowing of a single or solitary gallbladder stone. This is a patient, these both are similar or the same patients. In this patient, you are seeing there is an echogenic focus. However, the posterior acoustic shadowing is not pristine, it's not clear. You can adjust certain parameters on your machine to exaggerate that posterior acoustic shadowing, and that is called by changing the time gain compensation. The time gain compensation is nothing that tells us that as the depth of the soft tissue increases or the depth of the tissue increases away from our probe, more time is needed for the ultrasound beam to reach and thereby return back to the transducer. So by lowering the time gain compensation, you can allow echoes that are returning from deeper tissues, exaggerate those echoes that are returning from deeper tissues back to the probe. So by reducing our time gain compensation, we can exaggerate a posterior acoustic shadowing. This is a little bit about physics that tells you why some stones may shadow more than others. That depends on the location of the stone relative to the ultrasound beam. When the stone occupies the center of the width of the beam that's happening in our first instance, you will get a definite shadow. Okay, when the stone occupies the width of the beam, that means our probe is right on top of the center of the stone. When the stone is smaller than the width of the beam, or when the stone is out of the beam, or when the large stone is out of the focal zone, we may not get a complete shadow. We may get a subtle shadow, or we may get no shadow at all. So again, exaggeration or making a shadow more pronounced is in the hands of the technologist. Floating stones. Floating stones are those stones that are non-dependent. Floating stones are those stones that may be seen along the anterior wall of the gallbladder. Well, posterior to that, you just have a bunch of shadowing. There could be more calculi. However, the anterior wall is separately visualized. All right, now talking a little bit about tissue harmonic imaging and gallstones. The first image shows us the longitudinal ultrasound of the gallbladder where tissue harmonic imaging has been switched off. Here we see, well, I would call this gallbladder normal. I really don't see anything other than maybe a little more echogenicity along the posterior wall, which actually is not unusual, especially because the duodenal bulb is right there. However, when you put on tissue harmonic images, it increases the contrast. Tissue harmonic images just increases the contrast between tissues that have different density, and with this we are able to pick up smaller calculi. All right. So as we know that we will see gravitational dependence of calculi in many of our stones that are not moving, that are not shadowing. We are not sure that those are indeed calculi. Could they be small polyps? So what is the correct way to interrogate these stones with ultrasound? The correct way to interrogate them is a transducer as vertical as possible to the image along the anterior gallbladder wall. This is the correct angle of insonation. That means if the patient is prone, dip your hand under the patient and then scan the patient, rather than just going laterally and then scanning the patient. So what's correct? The transducer as vertical as possible to image anterior gallbladder wall, and what's incorrect? Its most dependent anterior part of the gallbladder is not well visualized. Remember, when the patient is prone, the gallbladder calculi will fall towards the anterior wall of the gallbladder, right? When the patient is supine, they fall towards the posterior wall. So our objective is not to identify the gallbladder fundus, which we are doing here, but to identify the anterior wall of the gallbladder, because the stones are along the anterior wall of the gallbladder now, and the distance from the probe is the shortest when you insonate it this way. Is that clear? All right. So pitfalls in diagnosis of a gallbladder stone. Residue in the bowel indenting the posterior wall of the gallbladder can mimic a gallbladder stone. We see it all the time. We don't know whether we're looking at a gallbladder calculus or if that's the anterior wall of the gallbladder of the duodenal bulb. We don't know what that shadow is coming from. All right, let's talk about a few other contents of the gallbladder lumen that could be sludge, pseudosludge, blood, pus, and milk of calcium. Biliary sludge. What is biliary sludge? Okay, biliary sludge is predisposed by a variety of conditions. Number one being pregnancy, rapid weight loss and prolonged fasting, long-term TPN, ceftriaxone, which is a antibiotic, and bone marrow transplantation. So patients who have undergone this, which are majority of the patients who've been on TPN, rapid weight loss, prolonged fasting, are our patients who've been indwelling in our hospital for a few weeks. I mean, they inadvertently have rapid weight loss, fasting, TPN, and all that. So if they said they followed, there were a couple of studies where they tried to follow these sludge within the gallbladder and wanted to see what eventually happens to them, and they said 50% of all sludge resolves spontaneously, 20% may persist, and that's usually asymptomatic. Only 5 to 15% will develop gallstones, and only 10 to 15% of all sludge becomes symptomatic. What are the complications of biliary sludge? Biliary colic, acute cholecystitis, and acute pancreatitis. Therefore, if the sludge is there of moderate to high grade, it is important that we report it. All right. So simple biliary sludge, also known as biliary sand. Why? Because it just looks like sand. It's grainy, it's like gravel. It's low amplitude, non-shadowing echoes in the dependent portion of the gallbladder. Occasionally sludge may be highly echogenic, but remember the sludge, it can move as the patient moves, it'll move as a layer, and there will be no posterior acoustic shadowing in simple biliary sludge. Pseudosludge. Pseudosludge is nothing but side lobe artifact. We see it all the time. We see sludge in the transverse view. We don't see sludge on the sagittal view, or vice versa. We can't convince ourselves, is there sludge, is there not sludge? That's mostly because of an artifact known as the side lobe artifact. It most commonly occurs along the posterior surface of the gallbladder, which is also the surface where the sludge will become dependent. It will disappear in different positions, and sometimes when the central portion of the gallbladder is scanned, then it disappears, as opposed to the fundus and the neck of the gallbladder being scanned. So this is how we differentiate from pseudosludge from sludge, that when we can see that actually it's not consistently available or not consistently showing off in all the projections. Now we come to aggregated sludge, that is also known as a sludge ball. Sludge ball is nothing but non-shadowing, mobile echogenic structures. Remember the word mobile. It's important to identify and important to demonstrate mobility of sludge balls. Otherwise, on grayscale, there's really no way to tell this from a mass. I could call this a polyp, an adenoma of the gallbladder, or gallbladder carcinoma, who knows. They change in appearance or disappearance on follow-up. So if you have a patient, you're not sure whether this is gallbladder sludge or this is gallbladder tumor, well, call the patient back in 8 weeks. If it changes morphology like a hemorrhagic cyst, it's probably a benign sludge. If it does not, then it needs further workup. And the follow-up scan, of course, differentiates sludge ball from a stone or a neoplasm. Aggregated sludge, that is also known as tumefactive sludge. We have discussed this in many of our settings. So tumefactive sludge is nothing but sludge that resembles a tumor. That's all it means, or sludge that looks like tumor. It's gallbladder with tumor-like sludge. Let's see this example, for example. There is mass-like, nodular mass-like echogenicity, which is seen along the posterior wall of the gallbladder. Well, if you show me this grayscale image, there is really no way I can differentiate tumefactive sludge from tumor. However, I asked the technologist, please move this patient around, let him walk, turn him around everywhere. If this moves even a little bit, I'm convinced this is not a tumor. Also, if we call the patient back in 8 weeks and this is decreased in size or rapidly increased in size for that matter, we know this is sludge, because no tumor will increase in size in a matter of 8 weeks. Well, coming to the question of vascularity, either with power Doppler or color Doppler, not all gallbladder tumors are highly vascular. That's the caveat to this. So if it does show vascularity, then I'm convinced it most probably is tumor. However, it does not show vascularity. It does not mean it's not tumor. It just means it's equivocal. It just means the patient needs to come back. What can help us identify tumor-like sludge? Potential mobility of the sludge, a normal gallbladder wall, no vascularity detection on ultrasound, and a follow-up exam. So don't hesitate to ask for a follow-up exam, okay? All right, coming to biliary sludge. Biliary sludge just means hepatization of the gallbladder. That means when a gallbladder is entirely filled up and distended with sludge, it is hard to identify that gallbladder. Biliary sludge, when it fills up the gallbladder lumen, can be a cause of non-visualization of the gallbladder on ultrasound. Why? Because the gallbladder entirely filled with sludge becomes isoechoic to the adjacent liver. That is called the hepatization of the gallbladder. And the only way we can differentiate the presence of a gallbladder to that of an absence of a gallbladder is by identification of a gallbladder wall. Can someone tell me how else in a patient with biliary sludge can we differentiate gallbladder absence with gallbladder presence? A postprandial exam. Have the patient eat something, a normal gallbladder will contract, the biliary sludge will be expelled out into the cystic duct and then to the common bile duct. If there was no gallbladder, the appearance will not change. Okay, blood in the gallbladder. Before we diagnose blood in the gallbladder, just remember, it's not a common diagnosis. It does not happen commonly. It's fairly uncommon. You should have some history available. Was the patient on any anticoagulation? Did we have any instrumentation of the gallbladder or the biliary tree? And what does it look like? So sonographic findings are echogenic or mixed echogenicity material that is seen in the gallbladder lumen, fluid with low-level internal echoes. Can anybody tell me in the ovaries, when we see an endometrioma, what do we see? We see low-level internal echoes. That's a cystic cavity filled with blood. Blood on ultrasound, whether in the ovary or in the uterus or in the gallbladder or in any hollow cavity, looks the same. Low-level internal echoes. That is, in the absence of septations, absence of nodules, blood in the gallbladder has a similar appearance. It's retractile. What does that mean? That means if you image the patient after 6 weeks or 8 weeks, the clot will shrink. It will undergo the phenomena of clot retraction, as does a hemorrhagic cyst. And it may be mobile. So gallbladder hematoma or hemorrhage in the gallbladder is not an instant diagnosis. It is a diagnosis after you've excluded a bunch of other diagnoses. They say there are a couple of findings that help exclude or include this in the diagnosis, and that is having beveled or angled edges. And I'm not sure how far this is true, because I really haven't found that as a very convincing feature of the 2 or 3 bloods that I've seen in my life. Okay, milk of calcium or limey bile. What is this? Milk of calcium or limey bile is highly echogenic material in the dependent portion of the gallbladder. And this can be confirmed by abdominal radiography or CT. An abdominal X-ray can confirm it. High attenuation material within the dependent portion of the gallbladder. So this is nothing but limey bile, concentrated bile that contains more calcium than others. All right, so this was abdominal radiography in a patient who has milk of calcium. All right, coming to the fourth entity, acute cholecystitis and its complications. Any questions? All right, let's keep going. Now, patient will not come in with gallbladder calculus or acute cholecystitis. Patient will present with a right upper quadrant pain. So, the various causes of right upper quadrant pain could be peptic ulcer disease, pancreatitis, hepatitis, acute appendicitis, hepatic congestion from right-sided heart failure, perihepatitis or Fitzhugh-Curtis syndrome that may occur in patients who have a TOA or any pelvic inflammatory disease, right lower lobe pneumonia, right-sided pyelonephritis, or nephroureterolithiasis. Therefore, in our institution, to encompass all causes of right upper quadrant pain, we are now visualizing the pancreas and the kidneys invariably, in addition to the liver and the gallbladder. All right, so in 2007, there were some Tokyo guidelines that were set forth for the diagnostic criteria of acute cholecystitis. In my recent M&M meeting, I have stressed on those, but let's talk about them once again. If there is a Murphy sign, either sonographic Murphy sign or clinical Murphy sign, that is pain or tenderness in the right upper quadrant in the expected location of the gallbladder on clinical exam, or you are probing right on the gallbladder on ultrasound, that is one criteria that is met. Second, fever, leukocytosis and elevated C-reactive protein, and confirmation of ultrasound by HIDA. As I have mentioned before, if a patient has at least one gallbladder calculus and a positive sonographic Murphy sign, with confidence, 95% of the times that patient does have acute cholecystitis. And we need to remember that. There may be no gallbladder wall thickening, there may be no pericholecystic fluid, and there may be no gallbladder wall hyperemia. Positive Murphy sign with one stone at least, that's diagnostic for acute cholecystitis. All right, you've seen many of these HIDA scans. So what's a normal HIDA scan? We see that the CBD is opacified with the gallbladder and the small bowel. There's radiotracer in the gallbladder, tracer in the common bile duct, and tracer in the small bowel. When you see this, there is no acute cholecystitis. But non-filling of the gallbladder with tracer in the common bile duct and tracer in the small bowel means that there is acute cholecystitis. Am I right, Piyush? Okay. Now, what are the sonographic findings in acute cholecystitis? Let's go through them one last time. An impacted stone in the cystic duct or the gallbladder neck with a positive sonographic Murphy sign or with distension of the gallbladder lumen is diagnostic for acute cholecystitis. Why do we make this very important? What is this gallbladder neck? Why is this so important? The artery for the gallbladder or the cystic duct artery takes off at the origin where the gallbladder neck is housed. So as the gallbladder neck keeps distending with a large stone, it can lead to gallbladder gangrene because of erosion or sometimes edema of the gallbladder with poor perfusion of the gallbladder via the artery to the gallbladder. So impacted stone in the cystic duct or gallbladder neck, positive sonographic Murphy sign, gallbladder wall thickening more than 3 millimeters, we're talking about the anterior wall, gallbladder distension of more than 4 centimeters. So hydropic gallbladder, the measurements are 10 by 5 if you take comfortable measurements, but 9 by 4 if you want to go very strict. So 9 centimeters in length and 8 centimeters in transverse diameter. Pericholecystic fluid collections and hyperemic gallbladder wall. None of the signs alone are pathognomic. However, a stone with a Murphy sign is pathognomic, a stone with distension of gallbladder lumen with 4 centimeters is pathognomic, so on and so forth. All right, let's look at this. This is a large obstructing stone within the gallbladder neck. As we all know, this is the gallbladder neck, and this focal dilatation is the Hartmann's pouch. thick hypoechoic gallbladder wall. In this patient, you see there is thickness of the anterior gallbladder wall, and there is indeed stratification of the gallbladder wall, and there was a positive sonographic Murphy sign. Even in the absence of thickening of the anterior gallbladder wall, this was diagnostic of acute cholecystitis. So here we know it's fairly easy. You've got calculus, sonographic Murphy sign, and anterior gallbladder wall thickening. Well, sometimes you can have a negative sonographic Murphy sign despite the fact that the patient does have acute cholecystitis. Well, patients who received pain medication or steroids, paraplegic or quadriplegic patients, patients that are not able to give a reliable history or a pain response, and a denervated gallbladder. In diabetes mellitus, you can have patients who have a denervated gallbladder because of gangrenous cholecystitis who may not elicit pain even though there is frank, abundant inflammation going on, and of course patients who have gallbladder rupture. Excuse me. Can there be conditions where you can have gallbladder wall thickening in the absence of acute cholecystitis? Yes. Generalized edematous states like chronic heart failure, renal failure, end-stage hepatic cirrhosis, and hypoalbuminemia. Inflammatory conditions like primary acute cholecystitis, chronic cholecystitis, and cholangitis. Secondary acute hepatitis, perforated duodenal ulcer, pancreatitis, diverticulitis, and colitis. And neoplastic conditions like adenocarcinoma, metastases, and adenomyomatosis, as well as gallbladder wall varices seen in a setting of portal hypertension. Let's talk about diffuse gallbladder wall thickening. We have three echo patterns that we need to identify for diffuse gallbladder wall thickening. One is uniformly echogenic, central hypoechoic zone, and two peripheral echogenic layers, and number three, which is a stratified pattern. Let's look at each of these. This is uniform thickening of the gallbladder wall. You see gallbladder wall that is obviously thickened, however there is no stratification. I can't say there's echogenicity here and hypoechogenicity there. This is just echogenic thickening of the gallbladder wall. This is most commonly seen in a setting of chronic cholecystitis. What else do we see in chronic cholecystitis? We see that in response to fasting stimulus, the gallbladder will not distend because it's fibrotic. The wall is fibrotic, it's thick. You may have the patient fast overnight for 12 hours, but the gallbladder will remain contracted. It will not distend secondary to fasting stimulus because of this thick echogenic fibrous wall. Now we come to gallbladder wall that is showing some degree of stratification. Central hypoechoic zone separated by two echogenic zones. Let's see this. You have an echogenic zone, and a central hypoechoic zone. Well, while this may still be seen in patients with early acute cholecystitis, it is most commonly seen in patients with ascites, that there is no real stratification. You just have a sandwich sign, two echogenic layers with the central hypoechoic layer. So sandwich sign goes with ascites. And then you come to this full-blown striated pattern, which is alternating echogenic as well as hypoechoic layers. See, echo, hypo, and you keep going. There's several sandwiches there like a club sandwich. So striated wall in a setting of acute cholecystitis can happen in gangrenous cholecystitis, and striated wall can happen even in the without the absence, well, in the absence of acute cholecystitis, there it becomes a non-specific finding. But let me break it down very objectively. If it was just echogenic thickening, it's probably chronic cholecystitis. If there is no stratification, it's just one sandwich or one hypoechoic layer, it's usually ascites or other causes which are systemic. And if there is marked stratification of the wall, it's usually acute cholecystitis with or without gangrene. Any questions? All right, let's go to gallbladder wall thickening. This is a patient who had peptic ulcer perforation, as we can see with the adjoining CT scan. We see this focus of air, and we see, of course, abundant pneumoperitoneum right adjacent to the ulcer. We see gallstones, we see focal gallbladder wall thickening measuring 7 millimeters, and we see free air with the reverberation shadows. This is the free air that they are talking about. This is the this is the free air that they're talking about, and this is the fluid that is seen adjacent to this gallbladder. Pericholecystic fluid, then this is the gallbladder stone, and there's extraluminal air. So this is focal gallbladder wall thickening due to adjoining inflammatory change due to peptic ulcer disease. Coming to gallbladder wall thickening in patients with acute pyelonephritis. Well, let's look here. This is gallbladder wall thickening, and if I had to choose which one it was, I probably would say it's the last one. It's striated. There are multiple echogenic and hypoechoic layers here. In the adjoining kidney, there's a 3 centimeter echogenic mass in the lower polar region of the right kidney, and that, of course, represents acute pyelonephritis on CT. It's hypodense, non-enhancing, and it's typical for acute pyelonephritis. Pericholecystic fluid, well, guess what? That also has two specific patterns, type 1 and type 2. So type 1 pericholecystic fluid is thin and echoic, crescent-shaped collection adjacent to the gallbladder wall. This is non-specific. This is seen commonly. It means nothing. Type 2 is round or irregularly shaped collection with thick walls, septations, or internal debris. And this is highly likely associated with gallbladder wall perforation or gallbladder abscess. Hyperemia of the gallbladder wall, it can be seen on color Doppler or better seen on power Doppler. It's increased gallbladder vascularity, and it is a supportive test. It's not a diagnostic test. Coming to a condition which is known as acalculous cholecystitis, and let's see what acalculous acute cholecystitis means. It usually is seen only 5 to 15% of all acute cholecystitis, and usually seen in critically ill patients who have had major surgery, severe trauma, sepsis, total parenteral nutrition, diabetes, atherosclerosis, and of course HIV infection. And they may be seen even in non-hospitalized patients who are elderly male patients with atherosclerosis. So it's the sonographic findings remain the same in the absence of a stone. Let's look at a few images of acute acalculous cholecystitis. They say it's difficult to diagnose clinically and even on imaging. However, here in the first example, we see marked gallbladder mural thickening with hypoechoic regions in the wall. So there does appear to be some gallbladder wall stratification, echogenic, hypoechoic, echogenic, and maybe more stratification in the fundal region. We don't see any gallbladder stone, however. Marked gallbladder mural thickening with hypo and hyperemic areas, which is diagnostic of acute cholecystitis. So common to know for all my technologists too, there can be gallbladder inflammation in the absence of stones. So those stones are usually present. It's not an invariable phenomenon. Now let's talk about some complicated forms of acute cholecystitis, like suppurative cholecystitis, which is also known as empyema, gangrenous cholecystitis, emphysematous cholecystitis, hemorrhagic cholecystitis, and then finally gallbladder perforation. So if anything, in our clinical practice, at best, we will see gangrenous cholecystitis, but I can assure that we'll really see emphysematous cholecystitis outside a textbook, or hemorrhagic cholecystitis. We may see gallbladder perforation, but gangrenous cholecystitis of anything, that's the one we need to look out for. So the first thing is suppurative cholecystitis. What is suppurative cholecystitis? It just means that the bile is not bile, it's pus, okay? That the bile has been replaced by frank pus. Patients are very ill with fever and acute pain. There are fine echoes caused by the pus in the bile. Pericholecystic gallbladder collection may be seen adjacent to it because there may be abscesses surrounding the gallbladder, and you can use, of course, interventional radiology to drain it. So just remember that suppurative cholecystitis is also a cause of hepatization of the gallbladder. It is also a cause of non-visualization of the gallbladder when it's distended with pus. Gangrenous cholecystitis. There are no specific ultrasound findings, however, there are several supporting findings. And I have shown all of you one or two images that have happened in our institution last year. So there is striated thickening of the gallbladder wall like you will have in any patient who has acute cholecystitis, but you will start seeing these membranes. This is a full-blown case of gangrenous cholecystitis. The membranes may only be seen in the fundal region, only in the body, only in the neck. Initially, we can mistake the membranes for being a sludge ball, but looking at it more closely, we can see that it's actually not a sludge ball, it's actually sloughed off membrane. There will be marked asymmetry of the gallbladder wall. There could be echogenic debris within the gallbladder. There could be pericholecystic fluid collections, just telling us that there is inflammation. And ultrasound Murphy sign is usually negative. Why? Because the nervous plexus of the gallbladder has also been involved with gangrene, and therefore the patient has no sensation overlying the gallbladder. All right, okay. Coming to another patient with gangrenous cholecystitis, this is another example where you're seeing mucosal sloughing. It's like a web, like resolving hemorrhage, or a web within the gallbladder lumen, intraluminal membranes associated with gallbladder gangrene. And in this patient, there was a stone with posterior acoustic shadowing seen in the region of the gallbladder neck. Coming to emphysematous cholecystitis. Just so that we all know that prompt surgical intervention is required, and when we suspect acute cholecystitis, I cannot always be 100% confident, yeah, what I'm seeing is definitely acute cholecystitis. Don't hesitate to order a CT. Don't hesitate to order an abdominal radiograph that will actually show you the air. There's no harm. Nobody will think of you less as a radiologist if you can't confirm your diagnosis on one modality. Just having a suspicion is enough. Organisms are usually Clostridium or Escherichia coli, and the characteristics are male patients, frequently occurring in the diabetic population. They lack gallstones in up to 1/3 of patients, and they have a higher risk of gallbladder gangrene and perforation. There are 3 stages: stage 1, stage 2, and stage 3. They say that there is gas in the gallbladder lumen, second is gas in the gallbladder wall, and third is gallbladder air in the gallbladder pericholecystic tissues. Can we tell these stages on ultrasound? Definitely not. And they say that like fluid, like sludge, like stones, even the air will seek gravitational dependence, and you can move the patient around and elicit the air. This is a patient who had diabetes mellitus and atherosclerosis, and we are looking for emphysematous cholecystitis. In the first example, we see intraluminal and extraluminal gas bubbles. Well, can I be confident that these are gas bubbles? We see them very frequently. I just call them echogenic sludge. I'm not sure in this patient that this indeed was air. And there's debris with necrotic gallbladder, which is seen in the dependent portion here. Higher sensitivity of CT definitely to pick up air as air anywhere in the abdomen, and diagnosis should be confirmed by abdominal radiography or CT. However, the diagnosis can be suggested on ultrasound. Emphysematous cholecystitis, this is a patient who had a focal amount of air. You see in the region of the gallbladder fundus, patient is supine and there's presence of echoes anteriorly, and this could be either in the lumen or in the wall. So on an upright position, obviously the gas moves and peaks to the, breaks into multiple bubbles, and it moves more superiorly, and this is what distinguishes it from calcium. Can we identify this as gallbladder air? Probably yes. This focus of a posterior dirty shadowing, a focus of echogenicity vis-a-vis the entire wall being echogenic, yes, that is suspicious. And if the same imaging appearance with change of patient position breaks up to tiny bubbles of air, could that be foci of gallbladder wall air? Yes, it could. When there is a large amount of gas, you don't see the gallbladder. All you see is a bunch of air. That is another cause of non-visualization of the gallbladder. Absence of normal gallbladder is the clue that you don't see a normal gallbladder. The gallbladder has not been removed. Gas in the gallbladder completely obscures the lumen, and this is the dirty shadowing. Why? If you compare it to the initial images of the confluent stone shadowing I have shown you, which was just black, which was just hypoechoic. This is dirty shadowing because there's a mixture of white and black. Location of the gallbladder fossa is essential to avoid mistaking this for bowel gas. And what is the expected location of the gallbladder fossa? Just look at the middle hepatic vein. Look at the confluence of the IVC with the middle hepatic veins. Go down in the plane of the middle hepatic vein all along inferiorly to the inferior edge of the liver. And if you cannot find a structure that looks like the gallbladder is absent. Just follow the plane of the middle hepatic vein on scanning the gallbladder. All right, this is emphysematous cholecystitis, as you all know, seen on abdominal radiography. Here theirs was intraluminal, which is all this, and extraluminal or intramural gas bubbles in the patient. Coming to gallbladder perforation, 5 to 10% of all patients with acute cholecystitis will ultimately perforate. There could be a small defect in the gallbladder wall. Well, is it always seen? No, it's not always seen. In this patient, this is the echogenic gallbladder wall. This was a focus where there was no gallbladder wall. This was a focus where there was, no gallbladder wall. And there was extrusion of biliary contents, maybe pus, coming out of the gallbladder lumen. And this was the area of disruption. Probably, was this an area of disruption? I'm not sure if this was a gallbladder wall or not, but here it looks like this could have been another area of disruption. The gallbladder will be deflated. The gallbladder will be like a balloon. I mean, it was distended, it was hydropic, it was distended with sludge, bile, pus, what else? Then, if it finds a little leak, it'll get deflated. There could be a fairly large pericholecystic fluid collection as expected, and that can evolve into a pericholecystic abscess. Here you see that there is gallbladder perforation with pericholecystic abscess, and the abscess is evidenced by a focus of fluid and air, which is an air fluid level in an abscess surrounding an inflamed gallbladder. Coming to hemorrhagic cholecystitis, like I said, very rare, happens in patients who have atherosclerosis for some reason and has a very high mortality rate. Echogenic material. with higher echogenicity than sludge. But what is higher echogenicity? What is lower echogenicity? You can tell if it's this high in echogenicity. However, if it's mildly higher than bile or than sludge, you really can't tell because it's very subjective. But if you have, just to remember one thing, two things with blood. Number one, history is important. Number two, if it's distending the gallbladder lumen, it will be very, very echogenic. And number three, it has angulated margins. Well, increased density of bile, here you see in a patient with this was hemorrhage within the gallbladder on CT with increased density of bile. Hemorrhagic cholecystitis, what is the differential diagnosis? Blood in the gallbladder can arise from a neoplasm, yes, from aneurysms, from trauma, anticoagulation, ectopic pancreatic foci within the gallbladder, and ectopic gastric mucosa which can lie within the gallbladder. High density bile can be due to recently administered IV contrast due to vicarious excretion and limey bile. Coming to chronic cholecystitis. All right, what are the forms of chronic cholecystitis? One is traditional chronic cholecystitis, one is the wall echo shadow complex, one is porcelain gallbladder, and the third one is the Xanthogranulomatous cholecystitis, and we'll discuss each of them. So a traditional gallbladder or chronic cholecystitis is a gallbladder that has marked thickened fibrous walls. It's echogenic because it's fibrous and it will not respond to fasting stimuli with distension. It usually does have stones. Chronically thickened, remember there's no stratification of the wall, uniformly thickened echogenic wall with a stone. Wall echo shadow complex. Now wall echo shadow complex is not a complicated thing at all. As the name suggests, ultrasound will demonstrate all three components of the complex. You will see a wall, you will see an echo, and then you will see a shadow. That's why it's called wall echo shadow. When they say the wall, they mean the anterior wall. Invariably in patients who have a markedly distended gallbladder packed with stones, you still will be able to see an anterior wall separated from the stones with a tiny amount of bile. So this first echogenic line is the wall. The second echogenic line is the echo, which is the echo produced by the anterior-most layer of stones. And then you have the shadow, which is the third part of the complex. So wall, anterior wall of the gallbladder, echo, the echo is produced by the anterior-most layer of the stones, and then the shadow, the wall echo shadow complex. The two parallel arcuate hyperechoic lines which are separated by a very thin hypoechoic space, which is nothing but a tiny sliver of bile, and there's distal acoustic shadowing. How will you differentiate this from air in the wall? If there was air in the anterior wall of the gallbladder, there will be no visualization of a complex. All you will see is a bunch of dirty shadowing. Let's go back to that image if we can. There is no wall, there's no echo. All there is echo and dirty shadowing. There will be no visualization of the anterior wall of the gallbladder if the patient has emphysematous cholecystitis, as opposed to patients who have a gallbladder packed with stones. So over here, all you see is echoes with dirty shadowing. Here you see is anterior wall stones with clean shadowing. Coming to porcelain gallbladder. Now porcelain gallbladder is a calcified wall with acoustic shadowing, and it can be mistaken for stone within the gallbladder lumen. However, usually no gallbladder wall is visible. Why? Because the gallbladder wall itself is calcified. So there is no separate visualization of this. You'll ask me, how can you differentiate a porcelain gallbladder from a focal form of emphysematous cholecystitis? And that's just a function of the shadowing. Calcium will never shadow dirtily. Calcium will always give you a clean shadow. So it's important to look at the wall of the gallbladder and also to look at the nature of the shadow, because remember we described shadows of the gallbladder, three types of shadowing. One is clean shadowing and one is dirty shadowing, and then this one was very clean shadowing coming from the anterior wall of the gallbladder. However, we don't see the anterior wall separate from it, so this is not a wall echo shadow complex. This is a porcelain gallbladder. This is dense calcification that we saw in a patient with on CT. A porcelain gallbladder with mild calcification. Just remember, if the calcification is interrupted, the shadowing will also be interrupted. If the gallbladder calcification is not dense and you will be able to pass the ultrasound between the calcifications, so you will actually be able to see a gallbladder lumen and the posterior wall if the calcification is interrupted. This is a porcelain gallbladder, just showing you that how it looks like on a X-ray. Coming to Xanthogranulomatous cholecystitis, just remember this is only 2% of cholecystectomy specimens demonstrated this form of acute cholecystitis or chronic cholecystitis. What do we see? We usually see a compressed lumen. Compressed means these are not hugely distended gallbladders. They are multiple hypoechoic mural nodules. What do we need to understand is that this star or the asterisk is the lumen. The structure from here all the way till here, all around in a radial fashion, is the mural thickening or the wall of the gallbladder. That's markedly thickened due to deposition of these fatty and foam cells and whatever laden macrophages that you have. So the gallbladder lumen itself is shrunken, but what you see is a markedly thickened gallbladder wall, which is usually concentric, and you can see these septations that are seen between the areas of fat, as you see on CT, like a radial appearance on cross-section. It's a compressed lumen, multiple large mural nodules separated by enhancing margins on contrast enhancement, and usually you don't see the stone itself because there is Xanthogranulomatous cholecystitis is not invariably associated with stones. Any questions upon Xanthogranulomatous cholecystitis? We recently had a case though. I don't know, Tom, if you were with me, or I don't know who was. You were, okay. So it is the abnormality of the wall, which is far more than the abnormality of the lumen, and that is a patient with Xanthogranulomatous cholecystitis. Okay, coming to gallbladder polyps. Classification of gallbladder polyps is into non-neoplastic and neoplastic. Non-neoplastic varieties are the cholesterol polyps, adenomyomatosis, and inflammatory polyps. And the neoplastic ones are the adenomas and the miscellaneous forms, which are fairly rare, like leiomyomas, lipomas, neurofibromas, and carcinoids. Risk of malignancy in gallbladder polyps. Small polyps are not necessarily benign, so we need to remember that. Sessile polyps that are less than 1 centimeter can be aggressive, but more than 1 centimeter are usually suspicious, and more than 18 millimeters are usually diagnostic of invasive malignancy. Here we are only talking about the sessile polyps. We will talk about pedunculated polyps in a minute. If the patient age is more than 50, there are concurrent gallstones, means that there is an element of chronic cholecystitis going on, and there is a presumptive diagnosis, or the patient has been diagnosed with primary sclerosing cholangitis in the past, then the risk of malignancy in that gallbladder polyp is increased. So let's look here. This is a cholesterol polyp that they're identifying in the first one, and in the second one they're just showing you the same anatomy, but you see multiple gallbladder polyps, which are also known as a strawberry gallbladder or gallbladder polyposis or cholesterosis of the gallbladder. All right, let's look at let's look at what the cholesterol polyp looks like and what is cholesterosis. Now, this is a single focal echogenic nodule that is seen along the anterior wall of the gallbladder, and this was non-mobile. So it's, well, this is a gallbladder polyp. That's the ultrasound description of a gallbladder polyp. And when you see multiple of those, that is known as cholesterosis or a strawberry gallbladder. Gallbladder polyps could be pedunculated, as we see here. Our gallbladder could be attached with a broad base to the anterior wall of the gallbladder here. That's a sessile one. And here it's pedunculated. Its base that is attached with is fairly narrow. Now, this is a algorithm that is not only followed by radiology, but it's followed by GI surgeons, by hepatology, by oncology. And let's say what it says. That if the patient has a gallbladder polyp of any size, but it is sessile, and gallbladder has stones, or there has been a previous or a concurrent diagnosis of primary sclerosing cholangitis, that gallbladder polyp has to be removed. So do we understand that? So if the risk factors are present, patient goes straight to surgery irrespective of size of the gallbladder. Size plays a role, less than 10, 10 to 18, and more than 18, depending on the symptoms of the patient, and of course we'll see in a minute. If the patient has a gallbladder polyp that is less than 10 millimeters, but the patient has symptoms, patient goes to surgery. If the patient does not have symptoms, we can image every 6 months. Likewise, in the 10 to 18 millimeter category, if the patient is symptomatic or non-symptomatic, it needs to be removed. and if it's more than 1.8 centimeters, patient goes for staging and open surgery. This is the consensus for guidelines. However, I have told many residents that we should follow up our patients if the polyp size is more than 5 millimeters, and we should recommend surgery at 1 centimeter, or at least when the patient has a polyp of 1 centimeter in size. I don't know what this criteria of that patient is. I can only tell you whether the patient has cholecystitis or the polyp has been sessile or pedunculated. Having not knowing that, at 10 millimeters, I recommend that the patient does have a surgical evaluation. All right. Now, this was just a study, and we don't necessarily have to discuss that, but they did evaluate multiple gallbladder polyps with endoscopic ultrasound, and this is what they saw. They said that the internal echo pattern was heterogeneous in 4 and homogeneous in 0, and it was hyperechoic spotting in 1 to 5 millimeters, and well, I'll show you the image and you will see what I'm saying. With endoscopic ultrasound, they are trying to classify polyps into either homogeneous or heterogeneous, and if they are heterogeneous, what kind of heterogeneity do they have? Are they just diffusely heterogeneous, or are there 1 to 5 echogenic spots, or are they less than that echogenic spots? We'll see that in a minute. So this is a patient who had a this is a patient who had a homogeneously echogenic, and this is fairly sessile polyp that is 11 millimeters in diameter. And did it have any hyperechoic spots? They said 5. In this patient, this was 9 millimeters in diameter. It was heterogeneous, and did it have any hyperechoic spots? Apparently 0, so the score was 13, and therefore this was adenoma and this was polyp. More number of echogenic spots within the gallbladder polyp points to more number of cholesterol crystals in that polyp. That points to more echogenic, more benign it is, and less echogenic foci, more malignant it is. You see what I'm saying? More echogenic or hyperechoic spots, more likely it could be cholesterol. Less the hyperechoic spots, most likely it could be adenoma that could become a malignancy. All right. Okay, now coming to adenomyomatosis, these are also known as Rokitansky-Askoff sinuses, and this is seen in 8% of patients who undergo cholecystectomy. They could come in 3 forms. Number 1 is the diffuse form, in which you have these sinuses as like a saw-toothed serrated appearance all along. Or you have the form which is segmental, you just see it in the center, and that typically has an hourglass gallbladder or a figure of 8 gallbladder. And then you have the fundic form, which is the most common, and the focal fundic form is also known as an adenomyoma. Let's look at this. Now, diffuse adenomyomatosis of the gallbladder. This is the comet tail or the ring down artifact that all of us have seen. What is it usually associated with? They say usually the anterior gallbladder wall is thickened, and you see multiple echogenic foci, some of which will show you this triangular shaped or ring down artifact, also known as the comet tail artifact. When you see this, that is a very convincing sign that this is not a stone, this is not a polyp, this is just adenomyomatosis of the gallbladder. Can these patients be symptomatic with biliary disease? Yes, they can be symptomatic. Coming to the diffuse adenomyomatosis of the gallbladder, here you see that there is a transverse image of the gallbladder, and you see multiple foci with posterior ring down artifacts. And in this, which is the MRCP, you see multiple high signal intensity structures within the gallbladder wall that give you a string of pearls appearance. Because remember, the abnormality is in the wall. These sinuses are nothing but, as we saw in this image, polypoidal projections, and these sinuses are right here, known as the Rokitansky-Askoff sinuses, which cause the posterior acoustic shadowing and then cause these multiseptate appearance or string of pearls appearance on MRCP. Coming to the segmental form of adenomyomatosis, you see this mass-like area that is obscuring the lumen. Any cystic spaces that are seen in the gallbladder wall also means that there is abnormality of the gallbladder wall, and diagnosis can go 2 ways. Cystic spaces in the wall of the gallbladder, in the absence of gallbladder wall shadowing, can mean either the Xanthogranulomatous cholecystitis, or it can mean segmental adenomyomatosis. Just 2 differential diagnoses that we need to see. In this segmental form, can we identify areas that have comet tail artifact? Yes, if we can, this was adenomyomatosis. If we cannot, then this is Xanthogranulomatous cholecystitis. So they're saying crystals that are these echogenic foci, they suggest the diagnosis. Sometimes fundal adenomyomatosis, which is usually the focal form, can appear mass-like. If you don't see a cyst and you don't see the posterior reverberation artifact, you can probably just call it as a gallbladder polyp or a gallbladder mass. However, they say that this also changes its appearance with distension and contraction of the gallbladder because it is a function of the gallbladder wall. Try and evaluate the patient in postprandial situation, or try and evaluate the patient after 6 hours of fasting. The appearance of adenomyomatosis will change. The appearance of a mass or the appearance of a polyp will not change. Okay, coming lastly to gallbladder carcinoma, there are three forms or major patterns of representation of gallbladder carcinoma. One is a mural thickening, one is a polypoidal gallbladder mass, and one is a gallbladder fossa mass, and we'll see the difference between the two in a minute. So mural thickening, it's the least common form, thank God, because it will confuse us a lot. Then there's focal or diffuse form, which could be irregular, and it's really difficult to diagnose whether there's mild irregularity or there's a mural thickening. Could that be due to adenomyosis? Could that be due to focal thickening of the gallbladder wall due to maybe ascites or non-gallbladder causes of gallbladder wall thickening? So that's fairly hard to diagnose. Polypoidal mass within the gallbladder, that's 25% of all carcinoma, is more than 1 centimeter, and there's a broad-based lesion, usually a sessile lesion, that is the one that is the culprit of the gallbladder carcinoma most of the time. And of course, role of endoscopic ultrasound is also just to identify what are the echogenic foci seen in that mass, more the echogenic foci, more the benignity. Coming to a gallbladder fossa mass, which is the most common appearance, and remember, this comes as one of the causes of non-visualization of the gallbladder. So non-visualization of the gallbladder, when the gallbladder has not been removed, could be several things. Number one, that it could be gallbladder carcinoma and the mass is replacing the entire gallbladder fossa and invading the adjacent liver, and you don't know where the mass begins and the liver stops. So this is an area where they're saying this is gallbladder wall thickening. Marked mural thickening of the neck of the gallbladder. Well, could you tell that this was marked mural thickening of the gallbladder or this posteriorly mural thickening of the gallbladder? Well, in this full-blown case, maybe, but this is the mural form of the gallbladder thickening. This is the second part, which is the 25% of the cases where you have usually a sessile mass, which in this case is showing vascularity, but it may not always show vascularity, and that is more than 2 centimeters, polypoidal mass in the region of the gallbladder fundus. There is internal vascularity, and on cytopathology, this was a villous adenoma. And do gallbladder masses usually enhance on CT? They usually enhance, but the enhancement is not always visualized because the enhancement is relative to the echogenicity or the density of the bile. If the bile itself is very echogenic, you may not be able to appreciate the enhancement. So that's not an invariable phenomena, and I recommend not using that too frequently. The most common form is the gallbladder carcinoma as a gallbladder fossa mass with non-visualization of the gallbladder. Here you see that there is a fairly large mass in the expected location of the gallbladder, which is going down segment 4A and then segment 4B of the liver along the middle hepatic vein. There are multiple gallstones that were giving some posterior acoustic shadowing, which are entrapped within the mass. So there are immobile gallstones. There's heterogeneous mass in the gallbladder fossa, and they were able to pick up some vascularity on color Doppler, and we can see the findings on the coronal reformatted images on the CT. So everybody remember, this is the most common form. That is, the patient says gallbladder is not removed, you're not finding the gallbladder, and all you see is either hepatization or you see a heterogeneous mass in that lesion. Okay, coming to the malignant tumors, as we know, adenocarcinoma is the most frequent. Unusual could be papillary adenocarcinoma, mucinous adenocarcinoma, signet ring, cell time, and we don't really need to talk about the very rare squamous cell carcinosarcoma, small cell carcinoma, or lymphoma or metastases. Usually on ultrasound you can tell one form of the other. All you need to know is that there's gallbladder stones that are not mobile, that appear to be trapped. There's some shadowing with the surrounding mass that's fairly diagnostic of a gallbladder. Well, we don't really need to discuss the Segmental. Okay, these were just a few interesting conditions. Number one is the volvulus of the gallbladder. This is not my case at all, but they say gallbladder volvulus, and it usually occurs as in volvulus, either with the spleen or volvulus with the cecum. Usually the suspending mesentery or whatever is suspending that organ is usually long, tortuous, and therefore easy to bounce around in the mesentery. It's a rare but acute entity. A patient usually presents with symptoms of acute cholecystitis. It could be seen in elderly females. And what do we see? We see a massively distended and inflamed gallbladder like you see in any patient who has acute cholecystitis, but the gallbladder location is funny. You know, the gallbladder location is not, it's not in the expected location of the gallbladder, and the unusual horizontal axis or the horizontal orientation of the gallbladder is, what gives you the clue to this diagnosis, as opposed to the oblique orientation of the gallbladder. I couldn't find an ultrasound image, but this is a patient where you had the fundus this way and the I think it's from radiographics or something, and the neck this way in a patient who has gallbladder volvulus, which is folded upon itself like a mirror image volvulus of the gallbladder. Okay, just one last thing I want to let you know, and all of us have been faced with this entity when we come to scan with the ultrasound tech. Patient says gallbladder is not removed. Tech can't find anywhere. You can't find anywhere in Epic whether the gallbladder has been removed or not, but you can't find it. Well, this could be one of the probable reasons why. Most commonly, previous cholecystectomy, patient is having a hard time remembering that, or there is inappropriate documentation in Epic. Chronic cholecystitis, a chronically contracted, thickened gallbladder. Even though the patient is fasting, it's not distending. Got contracted gallbladder in a patient with cystic fibrosis because it's just a fibrosis. A porcelain gallbladder with shadowing. So you see that there is a gallbladder, you see a bunch of shadowing there, and you're mistaking that shadowing coming from the duodenal bulb. It's not shadowing coming from the gallbladder wall. You think, all I see is shadowing, it's probably the duodenum. An air-filled gallbladder or emphysematous cholecystitis, again, you're seeing dirty shadowing and you think that's coming from the duodenal lumen, and you're not finding the gallbladder. Agenesis of the gallbladder, the ectopic location, a tumefactive sludge or hepatization of the gallbladder, and gallbladder carcinoma completely filling the gallbladder fossa. If there's one slide we should all take back from this lecture, it should be this one. This is just a patient who had cystic fibrosis. The gallbladder is chronically thickened and is not responding to fasting stimulus. Thank you.